Our traffic can join us. It's a bit of a end of this conference. Make it fine. I think we'll move on. Thank you very much for all those who traveled to come join this course. But I'd like to start by thanking Karl Storz, who essentially have been the force behind ensuring that this happens. We met with Karl Storz sometime last year and booked. Karl Storz actually had booked this surgical skills center with a view to try and promote the endoscopic skills around the regions. I think the invitation has been sent to colleagues of East Central Southern Africa. Others have already registered, but I believe that they were unable to finalize their matters. But thank you very much, Professors. You've been a huge help as a Karun with promoting endoscopic work here. We have essentially on paper a very exciting program of brain today, skull base and both ENT and surgical approaches tomorrow, and a growing field which some of us are becoming more and more proficient and interested in is spine endoscopy, which will be on Friday. As you noticed, we can try to keep the costs as minimal as possible, equivalent to actually going out for a lunch for a whole day. So the endeavor to promote teaching and training is part of what the Neurological Society of Kenya was formed way back in 1969, and it is the agenda of the Continental Association of African Neurosurgical Society. And so really this is in keeping with that program. So thank you very much for those who come in time. I think we'll get going. My mandate was to cover the upper brain, and obviously starting off, we must know, and that's why we are in the anatomy lab. If you do not know your anatomy, then you should be in business. You shouldn't be in surgery. You've got to know your anatomy, and because the emphasis is on endoscopic anatomy, it's an endoscopic course. It's important to convert that gross anatomy, microsurgical anatomy, into the endoscopic anatomy. The essence of today's endeavor, for those who will come, will be to focus on getting proficient at endoscopic third ventriculostomy and septostomy. Obviously, when you're in the ventricle, there is need to do a biopsy, there is need to do other procedures, but for this course, the emphasis will be on that, and there are models that are very nice that have been brought by Karl Storz, and we'll be dealing with that this afternoon. So we'll start off with endoscopic ventricular anatomy. Do we have a pointer? Thank you. Okay, fine. Thank you. So it's not moving.
Control the screen.
Just click on the next slide on the left column.
So it doesn't move with.
Yeah, can you click on that?
Can we control it?
Does it move if you click on that? Click on that.
I could click on that, but I was wondering whether
it's moving. It's moving. It moved.
All right.
Okay, it moved.
All right, now we're ready.
Look,
Okay,
beautiful.
so what are the indications where we will be doing endoscopic approaches into the ventricular system? The most common in our setting, of course, is obstructive hydrocephalus due to the variety of causes that we all are aware of. Aqueductal stenosis and childhood hydrocephalus is amongst the most common procedure that is done in our setting. Then one wants to manage arachnoid cysts within the ventricular system and also using endoscopy outside of the ventricular system. Colloid cysts of the brain, of the third ventricle is another indication. Biopsy of intraventricular tumors and tumors in areas adjacent to the lateral ventricle and the third ventricle. So these are the reasons why one would want to go endoscopically into the ventricle. Key to that, therefore, is the relationships that we need to recognize and understand. So the areas around the lateral ventricle, the third ventricle, and the fourth ventricle, less commonly we enter into the fourth ventricle, but we're always working within the lateral and the third ventricle. So therefore, we must know our relationships. The key relationships are outlined in this slide. We have your lateral ventricles. Adjacent to that, as you enter, you must be aware that if you're a little out of your position, you are at risk of entering or damaging the caudate nucleus. We have the thalami across there. And if you're way out, obviously there is the internal capsule, the globus pallidus, the putamen, and the claustrum are all, you can see them in gross anatomy, and you can recognize them in your MRI scans. So these are key relationships when you're entering into the ventricle. Internal capsule, the external capsule, the extreme capsule, subthalamic nuclei, substantia nigra, the hippocampus are all in the vicinity or neighborhood of the lateral ventricle. And when you next see your MRI, we know that we tend to just go by axial views, but if you look at these coronal views, you will be able to recognize these structures and have them embedded in your memory when you're doing these procedures. ETV, the endoscopic third ventriculostomy, is the workhorse of endoscopic work, and essentially when one is starting endoscopic work in the brain, your endoscopic third ventriculostomy is the one that one needs to become proficient. And essentially it is done through a burr hole right in front of the coronal suture. And if you're pedantic about it, it is 12 centimeters, and in children with hydrocephalus, maybe 13 centimeters from the nasum is where you find the cochleus point where you can do your burr hole. And that essentially has been chosen because when you're using a rigid endoscope, that line is the straight line between the basal cistern in front of the basilar artery and the foramen of Monro. Because if you're a bit further forward, you're going to struggle and pull upon the foramen of Monro, and on the fornix rather. And if you pull on or tag or damage the fornix, of course, the patient will have memory problems. So using that as a straight line, you see that you do not then target or damage the fornix going towards the basal cistern and right in front of the basilar artery. So that is your trajectory, essentially. The view as you enter into the lateral ventricle, as you enter into the lateral ventricle, and those who have been involved in endoscopy, the pristine because
hydrocephalus may be extreme, but what you're trying to look for is essentially this view. And the key to finding where you want to go is this structure here, which is the choroid plexus, this structure here, which is the thalamostriate vein. And sometimes you will see the septal vein on the septum, but if you see these two, where they join is where you really will find your foramen of Monro. And that is the view as you enter. You then get closer, and you then begin to see the fornix more clearly. As you begin to enter into the fornix, you get this view, and essentially that's the one that you want to find in an ideal situation. You want to identify your mammillary bodies and your tuber cinereum, and once you've done that, you then are able to perform your endoscopic third ventriculostomy. And then this is, so in an ideal setting, this is what you want to achieve. Get in, see your choroid plexus, your thalamostriate vein, your fornix, enter into it. You're entering into the third ventricle. As you enter into the third ventricle, locate your mammillary bodies and do your procedure. And we'll be practicing that this afternoon as to how to do that. This is a more detailed view of that anatomy, essentially showing us the foramen of Monro, the telachoroide, and the fornix. Now, what is the telachoroide? Essentially, you can look at it as the lamina propria of the ependyma. So these are folds of the ependyma. They are thin, highly vascularized, loose connective tissue portion of the pia mater found within the ventricular system. So if you look at it as the connective tissue within the ventricular system, and you look at that as the ependyma, essentially this highly vascularized loose tissue is what is called the telachoroide. In the lateral ventricle, it lies along the choroidal fissure. In the medial wall of the ventricle, the blood supply, and this is important because if you damage these, then you can get into problems. Anterior choroidal artery of the internal capsule, internal carotid artery, and several choroidal branches of the posterior communicating artery, posterior cerebral artery, are what supplies the telachoroide. In the third ventricle, it is found in the roof and is supplied by the posterior choroidal arteries. In the fourth ventricle, it is located in the roof of the fourth ventricle and supplied by the inferior cerebellar arteries. Now, essentially, when you've got the ventricle, you are able to approach it, and in certain procedures, you have to approach it from above. And that it's important to, that's the one that we've just described. You can also approach the third ventricle endoscopically from in front, and that is through the lamina terminalis. Therefore, you should be able to perform ventriculostomy through the lamina terminalis as well. So this is a view. And then the third way of getting into the third ventricle is when you're doing skull base surgery and you're coming in from below, and we'll see that anatomy as well. So this is, that was the earlier one was the anatomy from above. This is the anatomy coming in from in front where the lamina terminalis is. And essentially, you can open the lamina terminalis below the anterior communicating artery. If that is your anterior communicating artery, you've got your A1s on either side. Your lamina terminalis is here. You can open up the lamina terminalis just below the anterior communicating artery. The A2 usually then ascends in front of the lamina terminalis to pass into the longitudinal fissure between the two cerebral hemispheres. So when one is doing an ETV, if your third ventricle is occluded or fibrosed or has a lot of fibrous tissue, you essentially can do an endoscopic third ventriculostomy through your lamina terminalis, and this is where you are targeting. the third ventricular entry through the lamina terminalis via the supraoptic chiasm route. These are the anatomical landmarks. So you've got your anterior communicating artery, you've got your two A1s, and that's your optic chiasm. And in there is where you can get into your third ventricle. So you can essentially have an endoscopic view from in front entering into the third ventricle, essentially trying to show you the anatomical landmarks around that area. The anterior wall of the third ventricle is formed by the lamina terminalis, as we've mentioned. The roof of the third ventricle is formed by the telechoroide, which then presents as the two extensions of the telechoroide, which is the choroid plexus. So essentially, you need to be very aware, just like we mentioned in the relationships, that working in that area, you're working near the anterior communicating artery, you're working near the hypothalamus, you're working near the massa intermedia, posterior commissure thalamus are all in the region where you are working. The third ventricular floor, which is this one, is essentially going into the third ventricle, and then you could get into the then if you're going to, that's your posterior commissure, and this is the view from within the ventricle. The ideal view that you want to see when you're doing your third ventriculostomy is this. You see your mammillary bodies, you see your tuber cinereum, and you see your infundibular recess. Once you see this, you're pretty sure that that's where you want to be, and that's your most common. Not always easy, because in our setting, post-infectious hydrocephalus is quite a problem. But if you can identify the mammillary bodies, and mind you, in a lot of these hydrocephalic patients, they're fairly flattened out, and it's not easy to recognize them. But if you can recognize the outline of mammillary bodies, you know that that's where you want to do your endoscopic third ventriculostomy. Now, you can enter the ventricle while you're doing skull base surgery from below, entry into the third ventricle via the tuber cinereum. So rather than opening the tuber cinereum, going into the basal cister, if you're doing skull base surgery, you can enter into the third ventricle via the tuber cinereum. Mind you, and this is important, it's an important landmark, the distance between the two posterior communicating arteries is usually about 11.3 millimeters. So you've got a centimeter plus where you really need to remain in the midline, because you've got your posterior communicating arteries on either side. And that's the purpose of this slide, to show you that you haven't got a huge difference or huge distance between the posterior communicating arteries. So this is your endoscopic intraoperative view of structures of the foramen of Monro. This is your ideal. As we said, locate your thalamostriate vein, locate your choroid plexus. Where the two join is where you're going to get your foramen of Monro. And right there is your fornix, and that's your anterior septal vein. Oftentimes, that is not the one that you go looking for. You're looking for the choroid plexus and the thalamostriate vein, and bang, at the where they join is where your foramen of Monro is endoscopically. Pretty much repeating what we've just said. So what you do need to identify when you get your endoscope in are these areas, and you must recognize them every time you do that. The mammillary bodies, you will see the pulsating basilar artery. You can then see the floor of the third ventricle, sometimes fairly opaque, but oftentimes that's the tuber cinereum, where you can then see through. The clivus is seen through the third ventricle oftentimes, and then you see the infundibulum, and this is the view. This is the view that you get in a pristine ventricle, which is enlarged, the third ventricle that is enlarged. You see this, you're happy. Now, the membrane of Liljequist, it's important to recognize that there are made up of two leaves. There is the diencephalic portion, which comes from the front, and a mesencephalic portion that comes from behind you, if you're standing at the head of the patient. One of the key shortcoming mistakes one makes is going through membrane of Liljequist, thinking you have gone through, but you haven't gone through both leaves, and your ETV will fail. So you see your mesencephalic portion of your membrane of Liljequist. That's your prepontine cistern. And oftentimes, if you see you've gone through one layer and you're still seeing another, you haven't gone into the prepontine cistern. But if you can see your basilar artery very clearly, not covered by any membrane, then you know that you've gone through both leaves of the membrane of Liljequist. So there is the diencephalic portion, and there is the mesencephalic portion. So there'll be two leaves. Just remember, this is one leaf going onto the other. So you must go through both leaves before you get into the prepontine cistern. And once you get into the prepontine cistern, that's when you'll be able to recognize the posterior cerebral artery, the cerebellar artery. You'll be able to should be able to see them, but in most instances, what we're trying to get to is the prepontine cistern free of any Liljequist membrane. Again, same message, membrane of Liljequist, the diencephalic portion. You will see thalamic perforating arteries. And if you look carefully, and if there isn't too much scarring, you'll be able to see the third nerve and your posterior cerebral artery. So all these are beautifully outlined in a pristine. Now, an ETV has not been successfully done yet. You've opened up one membrane, possibly the mesencephalic one, but you have not opened up. And oftentimes an ETV will fail because you think you've gone through the membrane, but you're still left with this diencephalic membrane. Fairly easy to perforate with a balloon catheter because it will give way, but then dilate it, and then you'll see the vessels very, very clearly. You'll see the cerebella, but basically you want to see not the cerebral, you want to see the basilar very, very clearly, unhampered by any of the membranes. The structures that you will then need to recognize are the clivus, of course, the membrane of Liljequist, and a very unimpeded view of the basilar. And if you see this and you've got a balloon catheter, you can actually open these out so that you can get a good view. And then if you are going deeper, you will be able to see your sixth nerve and the anterior inferior cerebellar artery in that area. So that's where you are now reached once you've done your ETV. Very similar view. Now you're going further down. As you keep going down, you are able to see structures that are even deeper. You can go right down, if you have the right endoscope, to the foramen magnum. You can actually reach down the foramen magnum, see the medulla. You can see the vertebral artery coming up towards you, and next to it are the lower cranial nerves. You can see the hypoglossal. You can see the posterior cerebellar artery there and the 11th nerve. So these are structures that you can actually go. Doing an ETV, you don't need to go there. Done your opening, you've got a good CSF egress coming in, you don't need to go into that area. This is just to indicate that if you're going down, you can go down safely just behind the clivus towards the foramen magnum, and those are the structures that one will see. That's your endoscopic view. So why are we saying this? Because this is pristine anatomy, your normal anatomy. If you recognize that, then you will recognize that there are variations that are often found. And all of us who have worked in sub-Saharan Africa and in areas where there's a lot of hydrocephalus, we recognize that it almost looks like the variations are what are normal in some of our patients. So variant findings are frequent and very varied in infantile hydrocephalus. These findings increase the difficulty and operating time. So one should not go in saying, this is going to be a 20-minute procedure or a half-an-hour procedure, because in our setting, variant ventricular findings are almost the norm. Normal ventricular findings equate to shorter procedure times and success in accomplishing ETV. And a very good study done at the National Hospital by Ben, who said he was going to be here, Ben Okanga, actually showed that very eloquently. The times where and that led us to develop a grading system, which we call the African Federation of Neurosurgical Grading. We won't go into that now, but essentially, the higher the African Federation Neurosurgical Grading, the greater the difficulty of achieving success in endoscopic third ventriculostomy. That's for another day. So as in all surgical undertakings, the anatomy that's been outlined briefly in this lecture, it's important that a clear understanding of this anatomy is taken on board, and it's mandatory before you start embarking on neuroendoscopic ventricular surgery. Ventricular anatomy is prone, as we mentioned, to variant anatomy, especially so in the childhood hydrocephalus cases that we see in our setting. And recognizing these variations is just as important if we are going to be achieving success in endoscopic procedures. Thank you very much. Any points that you want to bring up? I'm sure that's very much the case in Egypt as well. I mean, I know that working with Nasser, the kind of hydrocephalus that that we see in that region is very much what we see in Sub-Saharan Africa as well.
Yeah, actually, we have multiple cases, post-infectious cases, and complex and complicated cases. And I agree with you that cases are very different experience in the hospitals. And the message you have just for the audience is to be patient with these cases and not to start, of course, with these cases, but to start with symptoms just before checking complex and complicated cases. Otherwise, you will be frustrated from the hospital. But they are challenging, and even when you see that your ETV is successful technically, even post-operative doesn't work. And even in post-operative imaging and MRI, the osteoid there and the anatomical area is targeted, but clinically the patient is not getting well. So there are also another pathologies that are not well addressed till now in hydrocephalus, as you know, the hydrodynamics of CSF and the changes happening in post-infectious hydrocephalus and post-hemorrhagic, even in neonatal cases, makes it a I mean, a lot of issues let the ETV not work very well.
Any pointers? Any I think all those in the audience have had the opportunity to go into the ventricles endoscopically. Have you had anything that you might want to add?
It was a wonderful presentation, sir. Very nice views of intraventricular anatomy. Thank you.
Thank you, Rakesh. Thank you very much.
Thank you.
You're from, where are you speaking from?
From India, sir, Kolkata. I'm a final year resident. I was very eager to attend this. It was a very good ventricular anatomy. Thanks.
Where are you speaking from?
India. I'm speaking from India, Kolkata, India.
It's very nice to know that our lecture is being broadcast. Thanks to John Bennett to India.
To
Thank
Dr.
you. Thank you. Thank you to John Bennett, and thank you to our local person who's been running around trying to do this, Dr. Khalif. Thank you very much. It's pleasing to know that we're on air and we're on the web, and it's being broadcast right through to other places.
Yes,
Good to hear from you.
we've also heard from Cambodia, Doc. They're watching there too, and they like the fact that we have a lab online.
That's great. So you've got Cambodia online as well.
Yes.
That's great. Thank you very much, John. You're
Sure.
doing a brilliant job.
Thank you.
I have to say that, because you've been very active in promoting webinars all across the globe. And it's not just the Western courses that are being put on, even the humble courses from places like the Nairobi Surgical Skills is now online. Thank you very much. We really appreciate that, John.
Well, it helps having people like Khalif to help.
Good. Well done, Khalif. Okay, so we're ready to move to the next talk. Essentially, that's going to be a more technical in the sense it's industry, because Mazen is going to tell us how ideally we should set up his equipment. Thank you, Mazen.
Thank you, Professor Qureshi. Can I use this or I use my laptop?
Yes. Khalif, you want to come over and help out here? There we go.
It's still on here.
You can just stop sharing.
So put your yeah. Yeah, sure.
Oh, you want to use it?
Yeah,
Okay, fine.
Just put it on the side.
Yeah. Maybe some of the people who didn't prepare with it. Yeah. Watching this.
Stay here this on the other side. There's this end. So it's good. Yes, enough. Is it this one? No. This one, this one. This one? Yes, this one. Good. So,
Yeah, just open the PowerPoint.
yeah, we're opening the PowerPoint, John.
Okay.
Where's the PowerPoint? Fix this one. This one. Yes. Good. They can see it themselves, right? Yeah.
Okay, you're sharing now.
All right. Yeah. All
Very
right.
good. Very good. You want to get a bigger picture? Okay, excellent, excellent.
Is that all right?
There you go.
Yeah. Good. Good. Very good. Thank you. So it's okay. It's okay. I just skip with the arrows.
No, it's okay.
What's fine. Interested in the
This is the same one with you? Yeah, yeah.
for the online audio. You can show them using the screen, the cursor. How do I do? So the cursor, the cursor. Otherwise, if you point them, they will not see. Okay. This is a new. That's what happened. So,
When, whoop, you slipped off there.
yeah. So we bought this one.
You
This one.
just go back to the PowerPoint. There you go. Okay, is that the PowerPoint you want?
No.
Okay,
It's not a problem. So
that's the last presentation, yeah.
yeah. So is this one here? You sure? Yeah, it's this one.
There you go. Whoop,
The
whoop,
previous-
back at the same one again.
All right.
Keep going to the, you had it.
So is this one?
Oh,
The previous one. Huh?
keep going to the same.
Yeah.
Yeah, we can close the.
Can you close this one? Yeah, I'm trying to close it.
Plus edit
Okay.
from the broadcasting.
Yeah. Can you remove that one, John?
Yeah, I'm
You remove the
sorry.
previous-
Yeah, it's a wrong presentation there.
Previous presentation.
You had his
All right.
presentation, but it disappeared. I don't know where it went. You want to try to get on his presentation again?
Oh, let me see. Maybe it's a flash card. Yeah. Yeah, just a flash card. Let me see. No. I realized the problem is the flash card.
Whatever you did before,
Yeah.
whatever you did, you had the presentation.
Yeah. See, it has to stay like that. Okay. So maybe move it to the other side. Now it's lighting up. Now it's lighting up. It's off. Okay. It's off. So it's the flash card. John, it's the flash card.
It's on again. I think it's off when it's not. When you press on it, it should turn on. This one. There should be ways to open it.
Yeah.
Just like this. Open.
Yeah.
Okay. Now it's working.
Johnny, okay there?
Not yet. Not yet. There you go. There you go. Looks good.
All right.
Yep, that looks good. Okay.
No, the C is off. No, it's just okay. That's fine. So, good morning. It's a pleasure addressing such a beautiful, small yet beautiful crowd. So, I'm Mazen. I'm from Cloud Stores. I've been working for the company for 11 years now. And just 3 years ago, I started promoting and talking about neuro and spine endoscopy, which has been a pleasure actually, because it was interesting to find out that house stores, when other companies gave up on neuro endoscopy because they thought this is a small field, it's not worth investing in. House stores being a reusable company concept, being a family-owned business, caring about medicine and about training and education. So for Mrs. Stores in particular, who's the owner of the company, neuroendoscopy has been a major interest. It's a field that we are investing in, and we're putting a lot of efforts towards research and development, trying to come up with product that surgeons like you can use for the benefits of societies and patients, etc., etc. So it's a pleasure to talk to you about our portfolio. I'm going to try to be brief. Please, if you have any question, let me know about them. Today, I'm going to present about upper brain, about cranial endoscopy, our portfolio in general. Tomorrow, I'm going to have, thanks to Dr. Qureshi, he included also a session about skull-based endoscopy. So I'm going to talk about how to build up a skull-based set, because skull-based instruments are so wide and variant, because there's the nasal phase that's different than the sinus phase, that is different than the cella phase. So each of them has specific instrument that is common between ENT in some cases and then neurosurgery on the other. And then on day 3, I'm going to talk about spine as well. To start with, I would like to change. If we take Kenya, for example, or African countries, with the verification, it's called the Viton 3D. We're going to try to have it tomorrow so that you can also take a look at it to understand what it is. So it's used for all type of microsurgeries, like in neuro, like in spine, as well as other specialties. And this is not a standalone solution. It's part of the same tower, of the same trolley. And then from the same tower, we can also
Ooh. Whoop, it fell off.
Sorry. No, I don't think so. The flash is working. Because it's still, I can see the presentation and then it just disappeared. Yeah.
Whoop.
It's the flash value. No top on it. Slightly disconnected.
That's okay. We're all new at this tech.
On the other side, then. Yeah, let's remove this one.
It's the flash that keeps disconnecting them.
Let's try it here.
Uh,
On the laptop, we save it on the desktop. Yeah. If it will continue doing this, we don't have to. Yes, it's this one. Can we just take it, copy, paste it here?
Makes sense.
Let's press this one.
Yeah, yes, this one. All right. Okay, we're quitting, John. There's a problem with the slides.
Okay, we're not seeing anything yet.
Okay, let me.
No,
try
it's
to
working.
use-
No, it's working. Sorry. Can we just, how to go full screen with this?
Yeah.
This one?
Problem is, keeps commenting. This guy.
It's working. But now it's on the laptop, actually.
You see?
Oops.
Yeah, battery low, so
Yeah, you need to try.
you should charge.
It's hospital. I think it's here. Is it the first one up with decoration?
Yeah.
Hassan, USB is for this or for this? For this one.
Interrupt you. You step on the other side.
I'm gonna go to the other side since if this will work.
Yeah.
So I think no. He wants to thank us.
Yes, he keeps thinking.
Yes. Yeah.
The first
Yeah,
channel
yeah,
I
this one.
operated in Zanzibar. So.
Let me.
I was telling Dr. Hassan this morning about the interesting story that I heard you presenting before.
This is not your slide. This is
No,
not
no,
your
it's
slide.
not my slide.
Already published it in Antarctic, yeah. But not, of course, in more details.
Where's your flash?
No, it's already on the
Is
it's in the computer.
it?
It's in the back somewhere. Yeah, it's just passed.
All right. So you know what? We're going to quit. Just.
Yes, that's one. Share.
Oh, there you go.
No, it's not.
I don't know.
it's
I
not-
think
no,
that's the previous.
not the previous one. So I don't know what keeps persisting.
It's this one. In here. I'll press again here.
This is
Yes, I think no. Yeah, no, it's coming. No, it's coming.
Yeah.
Okay.
But you're not connected to the audience.
Is
the
it?
international audience.
Okay.
John, can you see anything?
Not yet.
Not yet. So I'll have to share. See this problem. So that
Okay.
is I have to
So the
see.
presentation's on a flash drive.
It's on a flash drive.
No,
We can
we
see it here, but then we can't put it online.
We did. We copied. We pasted on the computer now, so we're running it.
Yeah, you had it before. Whatever you did before.
Where's the
No.
one?
No, this is the.
The one. This is the one that I want to do. So this
Can
one
you
put
delete
it
the
down.
previous presentation from the list?
You can do it yourself.
He's the one who's controlling the slides. Can you hear me, John?
Yeah, I can hear you fine.
So can you delete the previous presentation completely from Zoom? So that's your slides.
It's still the same presentation, I think.
This one.
Yeah.
Yeah.
You okay now?
Yes, yes,
Yeah. Okay. That's
yes.
That's
It's where it left off last time.
Yeah.
There, very good.
Nothing. I'm just gonna press the arrow.
Very good.
So I was talking about one system to do all microsurgery with the VTOM 3D and then endoscopy, whether 3D, which is a state-of-the-art advanced technology now, especially in skull-based surgery. And then there that can be part of the same tower, starting with the 4K, which is an 8 million pixels, going to the normal HD, which is 2 million pixels, We have them in autoclavable and non-autoclavable. And then we have the ICG camera for the ICG scopes in order to detect blood protrusion into different tissues, as well as to identify normal and abnormal tissue, to differentiate between normal tissues. And tomorrow I'm going to share some studies, and I'm going to talk a little bit about some applications for the ICG in neurosurgery. So, and then also on the same system, we can connect the flexible scope. Also, we have a flexible scope available for you to try and to see for ventriculostomy. So it's all part, the message that I want to deliver, it's all part of one system. The whole system, it costs less than an operating microscope, a good operating microscope, I mean, an average to a high end, and yet it can be useful for practices in a lot of places. So, for you to know, an endoscopy tower consists of a monitor to see the image, a camera to transmit the image from the human body to the monitor, because you're working in closed cavity. You're not opening, and you're not using OR lights or outside or headlights. So you need a light source, which is a lamp that just transfers the light into the cavity inside. And then the cable transmits the light from the light source to the scope, which is your eye inside. This is what's going to be inside visualizing. And then documentation can be anything from a USB on a camera to a printer to a DVD recorder, or it can be an advanced documentation system where you can also put your comments, voice and written comments. You can document video and images, as well as can be connected to the hospital information system and the PACS system of the hospital to extract images from the PACS, radiological images, or to send directly when taking a photo in the OR, directly stored on the hospital information system. So it can all be part of a small documentation unit, which we call AIDA in stores. And then the unit specific for neurosurgery, like electrosurgical unit for bleeding management and bipolar and monopolar coagulation, and then the motor system for perforating, for craniotome, for the different drill system available. Different approaches: upper brain, skull base. Today, the upper brain is the parts. Our motor system has all the accessories that is needed, from the perforator to the craniotome to the different drills available in diamond, standard, coarse diamond, fluted, coral burrs, or are available for use. Moving into shunt placement, which is a standard procedure in neurosurgeries. A lot of patients can only be treated with a shunt, especially where other treatment like ETV, for example, did not work. For that, what we offer is a shuntoscope. It's a simple needle, 1 millimeter semi-flexible telescope that is connected to any endoscopic camera you already have. It's reusable, it's autoclavable, especially with the new version now, which I'm gonna come to. And the objective of it is to place the catheter of the shunt under endoscopic view, to place it inside of the ventricle. And it can be used for difficult anatomy in cases of trauma, cases of accidents where the anatomy has shifted or changed inside. It can be used in cases where the foramen or the ventricles are very small. So to access it with the shuntoscope under endoscopic vision, of course, for documentation and surely for training, because a lot of senior neurosurgeon, they can blindly place a shunt. But sometimes also it's good to have such a product to teach others, to show residents and fellows how to safely place a shunt, because failure of shunts, a big percentage is due to malplacement from the beginning. Now, the new version is autoclavable. Not only this, but also it has a working sheath with it, where a ventriculostomy forceps can be inserted for ETV, where biopsy forceps can be inserted, scissors and a grasper can be inserted, as well as a monopolar booby wire, which is the electrode, polar electrode. I met a surgeon in Russia. I don't know if you met him in Cairo, Dr. Qureshi. He's Albert Sovyanov from Tuymim. He uses this for a lot of cases. He uses it for aqueductoplasty, for ETVs, all of his ETVs, for biopsies, of course, as well as for shunt placement. And he promised us to send us some videos that we can share with surgeons, which I'm waiting for, which is actually interesting to know. So the new version is, of course, autoclavable, but the previous version was not. So this is regarding the shuntoscope. And then moving towards ETV, which has become, for a lot of surgeons, the first line of treatment in neurosurgery. So a product map or a portfolio map that we have the gap system, which is still available. Some surgeons, they like it because it can connect with it the CUSA, which is an ultrasonic aspirator. It can connect to the gap. The LUTA, or the little LUTA, which is the newest among the upper brain portfolio, which is our focus product because surgeons' acceptance is very high. They accept it. It's rigid. It's more rigid than the gap and the OI, because the gap and the OI, there's the sheath and there's the scopes that are different. So anytime the scope can be broken, and then the whole system is malfunctioning. While the LUTA and little LUTA all are embedded into one. So the sheath, the scope, irrigation, suction channel are all in one, and it's more rigid. And I'm gonna share some photos as well to see the image quality of the LUTA. The optics is really incredible. And then the OI, which a lot of surgeons, they like it. It's a handy pro. It's easy to use. It's like a gun that you hold it, and then you have a sheath, and then you have the scopes that you put inside the sheath. Also, we have them available. We have the LUTA available. We have the OI available, so that you can have a look at them. And then the instruments are just like the LUTA and the gap instruments. So ventriculostomy, biopsy, grasping forceps, scissors are similar, but of course in different sizes. The flexible scope, the shuntoscope that we talked about, and then the GMB scalp dura retractor is for endoscopic assisted craniosynostosis surgery. Also, I'm going to talk about it in 2 slides. First of all, the LUTA. There's the big LUTA, there's the little LUTA. Some surgeons, they use the big LUTA for adults and the small LUTA, the little LUTA for pediatric. Other surgeons, they use the little LUTA for adults and pediatric for only ETV because it's a small size. It's similar to the size of the OI, which is a small size. So, and then if they want to do bigger surgery, like tumor, like cyst removal, they use the big LUTA because it has a larger working channel where they can aspirate and they can grasp more tissues from inside. So we have them in 6 degrees, not in 0, while in the OI we had a 0 and the gap it's a 0, and the LUTA it's a 6. Why 6? Because as soon as the instrument tip comes out from the working channel, the surgeon wants to see it. Not to go a little bit far so that they see the tip with the 0 degree. So with the 6, you see it as soon as it comes up, the head comes up, you can see the instrument easily. And also the LUTA are available in 30 degree, especially to see the aqueduct as well. So available in both, but 6 degree is the mostly used telescope. And then the instruments, these are the general instruments that are common for all the system. The scissors, biopsy, I'm sure that you all know them very well. The ventriculostomy, which is very important to penetrate into the floor of the 3rd ventricle in an ETV case. Grasping forceps and biopsy forceps. And also for bleeding management, there is the bipolar forceps and there's the bipolar electrodes that surgeons, they find useful as well in ventriculostomy, the electrode, the bipolar electrodes. And then there's the suction and irrigation channels that we can see them in the LUTA scope, which we said it's part of one, it's grouped in one. And then the central working channel, which is this channel right here. Okay. Now, what's the difference between, for example, if we take the gap, which is this one, the working distance of instruments is open, it's flat like this. While with the LUTA and the little LUTA, it's a dedicated working channel. So it means that the instruments cannot move. So it goes only in one direction. If you want to move, you just move a little bit the telescope so that you access a different area. And that's what the concept of the LUTA was. So to have dedicated working instruments. It's worth mentioning something that all of these instruments, and which I mentioned before, is in the color of KARL Storz, is everything is reusable. We don't focus on disposable parts, and we're not interested in disposable and single-use parts. Because a lot of companies, they just come up with instruments that are single-use. And they get them into insurance and coverage and national social security so that they can make more turnover. For us, we focus on quality sales and not on quantity sales. It's not volume sales for us. For us, a small LUTA set means a big project for us. So this is how important it is neurosurgery for us. Now, for the LUTA as well as the other, introduction of the sheath, this is a step. It can be done in several ways. It can be done using a navigation system in developed ORs. It can be done using a Pilewy sheath as a basic solution to have it inside and to measure the distance. Or instead of the normal obturator, we have an optical obturator where we can have a scope inside of it and a camera on it, and then we can introduce the telescope in the ventricle under endoscopic vision rather than doing it blindly. In some places, they're finding it cheaper and a valuable solution to use. And then once the sheath is in, obturator is out, and then telescope is in. So this is how From the outside, from the technical part, this is how it's used. For the inside, of course, the professor, I mean, we're gonna have a lot of discussions and times with them to get to know that. Now, this is the ventriculostomy forceps on the left. We see it just above of the mammillary's body. And then the balloon catheter on the right that can be used to, as Professor Qureshi just mentioned, to expand the opening and to make sure that no recurrence will happen by closing of the floor. So, and this is, I want to show also the quality of the Lotta telescope. The optics of the Lotta are quite high. And this is another image as well that shows the quality of the image of the Lotta telescope. We have the Doctor to Doctor, which is a silver book written by Professor Schroeder. And we have a quantity around 10 here, hard copies, as well as we have soft copies that we can send you. So at the end, you will be having a copy and then a DVD as well of a step-by-step, not only ETV, but also patient positioning, instrument positioning, as well as more advanced cases like tumors, like colloid cysts performed. So this is also for you that you're gonna receive at the end. Bimanual instrument working. The Lotta system can be fixed. Some surgeons, they prefer to keep it mobile because they're afraid if they fix it and if the patient moves, then it's a catastrophe. They prefer not to fix it, to have it mobile so that if the patient moves, they move with the patient. Some surgeons, they like to have it fixed. They trust the anesthesiologist. They know that the patient will not move. And then while having it fixed, you can have a bimanual working, like a colloid cyst procedure in the right picture. You have a grasper, which is the flexible instruments on the left that is going from either the irrigation or the suction channel. And then from the central working channel, you have the 2 millimeter bipolar electrode so that when you're pulling, you are the bimanual technique that can be done with the Lotta. Dr. Qureshi, with the OI, bimanual can also be done? Bimanual working. With the OI, no. Just the central working, just, yeah. So these are the different dimensions. I mean, these are technical details I'm not going to spend time on. Just for you to know, if you can just look at the outer diameter and the inner diameter. So outer diameter for the Lotta is 6.8, little Lotta is 4.5, inner diameter is 3.6, and then 2.4 or 2.3 for the little Lotta, which is the central working channel. The same system can be used for a lot of ventriculostomy cases, of course, starting with, as Professor Qureshi was mentioning yesterday, with the basic procedure first, septostomy and ETV at first, but also it can be used later on to address bigger procedure. I received a paper lately about a hematoma in the brain, where a surgeon used the Lotta and then used sort of evacuations like suction catheters to remove the hematoma after a trauma case. I'll be glad to send it to you and to get your feedback also on such a procedure that can be done. And he used the Lotta. He had the Lotta and he used it for that particular case. Now the flexible, this is the new video flexible. It's an HD image. Here we have the old fibroscope that can be connected on any endoscopic camera. The image of the new one is much better than the old one. Yet the old one was a workhorse for neuroendoscopic surgeon. I mean, especially on the African continent, where they have the most experience with fibroscope in the world. And a lot of surgeons from Germany, from Europe, or from the US in general, they come to Africa to learn about flexible endoscope because they don't have the experience that it's on the African continent. And so the new flexible, it's deviating up to 270 degrees, both direction, the deflection. It has a working channel of around 35 centimeter. The whole telescope is around 40 centimeter of length, and it needs the HD camera to connect to. So it cannot connect to any camera, while the fibroscope can connect to any camera, as we're gonna see this afternoon. Craniosynostosis, whether sagittal or coronal, a system was developed and to do endoscopic assisted. So instead of having a big opening, for example, for the sagittal craniosynostosis, to cut this bone that has fused, the suture that has fused, the idea here is to have 1 or 2 opening, and then under the skin, because the retractor will have 1 to protect the dura, 1 blade to protect the dura, and 1 blade to elevate the scalp. And then with the scissor, the surgeon can cut in between. And the good thing about endoscopy is that you can see the bleeding where it's happening. So you can coagulate on the spot. While if you have a complete open, you will have a lot of bleeding that it's not easy to know from exactly the bleeding where it's coming from. So instead of coagulating everywhere. So blood loss is less, surgical time is less, baby can be discharged second day or the third day, not like an open procedure where more time is needed. The surgeon who developed the system uses a kind of a helmet to remodel the skull after surgery. But a lot of other surgeons, they use the same instrument but without a helmet. So they just follow up with the baby. All of the instruments you see on the left, from the bipolars to the scope, these are all standard instruments from Skullbase available already in the OR. So what is needed is only the scissor and the retractor. And these are both, again, reusable. So they will be used for a long time. So another solution that I wanted to present. So with this, I come to my end. So the Skullbase, I'm going to leave it till tomorrow. Maybe I'm still ahead of time. If you have any questions, I will be more than happy to answer them. Yes.
Thanks, Nasser. I just have 2 questions.
Yes.
What's the biopsy volume on the small one? Can you get like a good sized chunk, or it's just?
It's a small chunk because the instruments are 1.2 millimeter. 1.2 millimeter of instruments are truly small. What do you think, Professor Hazan?
With the letter doctor, you need to have more than 5 or 6 biopsies because the pathologists will not be happy with the single biopsy because it's very small. I do remember the first case I had with the letter doctor. I just managed to take a single piece and the pathologist couldn't do anything. So later on, I usually use the letter doctor for more than 6 or 5 biopsies, 5 to 6 biopsies. But with the normal doctor, the big doctor, I think that 2 would be enough. Again, don't depend on the single one. 2 would be enough.
I think it's also a question of getting our pathologists come used to it. When we first brought in our Cape Town stereotactic pointer, they were cursing us. So what have you brought us? You're giving us very small pieces.
Yeah.
But very quickly they became proficient. Yeah. If you look at our over 120 now tactic biopsies, the first ones, in fact, one was a disaster because it was a tuberculoma. They called it glioma. This was very tiny, and they obviously looked at tissue surrounding. But very quickly, their learning curve, the pathologist learning curve, came up, and we were getting good histology. The same with we do our biopsies because that's what we have with our OI. The OI forceps is very tiny. Yeah. So, like you say, if you do multiple, you need to do multiple. I would say 4 is the minimum because oftentimes with 1 or 2 you may not get the tumor. Can be done. So even with a little LOTA, you can get the messages that you need multiple.
And it's better just to, just like in stereotactic, perhaps it's better to take them from different quadrants of the tumor. If it's technically applicable, of course, yeah.
So I think it's encouraging them to work with smaller pieces because it's very often they would say further biopsy is recommended. Yeah. So I think the little LOTA will give us bigger pieces than the OI. Should be.
I don't have any experience with the OI, but in the past I used the GAP. Currently, I use the LOTA and the letter LOTA. So I prefer to use the LOTA for biopsies, but in the pediatric age group, and especially in young children with a small head, I prefer to let it up. So I have to take much more than 4 to 5 biopsies.
And just the last one. What resolution on the new flexible? Is it much better?
Yes.
It's not comparable at all. This is another story.
Yeah.
The problem is still that it's not autoclavable.
It's not autoclavable.
Yeah.
But it can be used. It can be autoclaved by steam.
Yeah.
Steam is can
sterilization. not
steam
autoclave.
sterilization.
Not
Yes.
autoclave.
Sorry. I mean plasma. Plasma sterilization.
It's a gas sterilization.
Plasma, yes, but the problem is the plasma is not available in all hospitals, and then the sterilization cycle, because of the filters and the solutions. And to rinse with distilled water before putting in the Sidex, because if you wash with normal tap water, there's minerals in waters that will do reaction with the Sidex. If there's a blood inside the working channel, everything has to be cleaned well before putting in Sidex, because the blood, which has protein in it, with the Sidex, it will stuck on the instrument. So the Sidex, while it is a strong chemical and it's not a sterilizer, it's a disinfectant, still there are some things that can be done in order with Sidex to avoid damages of instruments or contamination.
The actual problem is that the infection control in our hospitals now are abolishing use of the Sidex. So
Yeah.
this is a problem. So
Is there an alternative? So I heard that J&J came up with a new types of a solution.
I heard about it, but it's so expensive. So again,
okay.
the hospitals couldn't.
That's another
manage
challenge.
to,
Okay. Because I heard that it solved the issue of the normal Sidex, that the reaction.
But still, it's the disinfectant, not sterilizing.
Still not a-
Yes, still the same problem with infection control.
Okay. Thank you, Dr. Hassan. Any other questions? All right. Thank you.
Thank you very much. I think we're in time for the break, and then come back to the next two lectures.
Good morning. I'm David Oluocholunya calling from Nairobi, Kenya, and it's an honor to present this morning. We've had presentations from Mahmoud Qureshi and Basin as well in terms of the equipment that is utilized. My job is give a small view of endoscopic third ventriculostomy, some of the techniques and avoidance of complications. Well, I thought I'd start by mentioning our neighbor who's now gone back to the US, Ben Wolf, who did most of the work in terms of ETVs before 2006. And in Bale, Uganda, he was using a flexible scope. When I got back from the UK, I used a pediatric cystoscope, which is also made by Karl Storz. John, can you hear me? Sorry for interrupting. John?
Yes, we're not seeing a presentation.
Please use David's screen.
Yeah,
Project David's.
I can see. Okay, which screen do you want to screen share from?
We screen sharing from David's.
Okay, whatever. Fine, that's fine. Wherever you screen share, I'll show it. Okay. Okay, you got it. Perfect. Okay, perfect. Can you hear me okay? Oh, it's frozen. Can you hear me
Oh,
okay?
you're using Mahmoud.
Oh,
It's good.
I
It's
can,
good.
but it's not projecting. So no screens were shown, but shall I go back or just continue?
Well, you can go back if you want.
Yeah, I said I'll just thank you for. I hope now with all the technical teams around the globe. My name is David Oluchilunya. I'm a neurosurgeon in Nairobi, Kenya. I work with Mahmoud Qureshi, and we thought I'd just share some thoughts about endoscopic third ventriculostomy and some of the techniques in terms of avoidance of complications. I thought I'd put Ben Wolf there because he's one who's done most work really in terms of endoscopic third ventriculostomy. He was using a pediatric cystoscope, and it was a flexible one. Kenya is right next to Uganda, so it's part of our claim to fame. I started doing endoscopy here before 2006 using a pediatric cystoscope, which was from Carl Storrs. It was the only rigid scope that we had available, and I had borrowed some Fogarty balloon catheters. I started using a forceps, bronchoscopy forceps, to do ETVs, and I thought I was being clever, but Philippe Deck actually published this in the as a case report and technical notes in 2000. So after that, it was accepted that this was a way forward. Now, in Kenya, we had a watershed year in 2006 because a group of us went to the IFNE in Lyon, France. We met José Piquet and Shizuo Oi. There we see José Piquet with one of the first courses we had here. We use the Oi endoscope, and you can see how, in terms of utilizing it, some of the things that we worry about is a free-handed technique has to be stable. Now, there are actually three neurosurgeons who was watching José Piquet to stabilize it. We were told earlier how we use a sheath, and it's important that, as it is like a gun, you secure it next to your body so it does not overshoot. The first endoscopy was done. 3 neurosurgeons. There's Mulunga there, worked with José Piquet, with the Shizuo Oi endoscope. It has been secured, not a free-handed technique, and with that, Jose is gripping it close to his chest. They're all looking at the tower, and that's one of the techniques to make sure that you do not overshoot. Mahmoud Qureshi doing the same. Same thing, somebody securing it on the table. As he had mentioned earlier, we have excessively large hydrocephalosis. Shizuo Oi called it mega hydrocephalus, and you can see on the patient's head, it is actually trans-illuminating because there's so much fluid within it. In terms of techniques, the irrigating tubes that we have, light source, we were shown about the use of towers, but we used the Telepac system. Telepac, it has all-in-one, the screen, the light source, and there's the Oi endoscope, like a gun, and we said that this is like the 007. So this Telepac system traveled around the region, and it has been published in neurosurgery, World Neurosurgery. Both Mahmoud Qureshi and José Piquet have published that. The usefulness of it, it's portable, and you do not need the maximum tau for it to be able to work. This fits in a suitcase, and for our setup in this region, it is very useful. What I will do now, I think you had the anatomy shown earlier on by Mahmoud Qureshi. This is an example of using the Shizo Oi. We went through the sheath, entering foramen of Monro. As I told you earlier, in our setup, we sometimes have very thick floor of the third ventricle. This one is not too bad. You can see the infundibulum of the pituitary, and that's the floor of the third. The mammillary bodies are there, widened. And in this particular, you can actually see the pulsation of the floor of the third ventricle. Now, the technique that was shown earlier, straight down, holding it next to your body, the free-handed technique is what we utilize. And for the patient's heads, we sometimes just secure them using simple tape, the 3M tape, so that the head does not move around much. In this particular demonstration, we'll be using a Fogarty catheter. Now, the Fogarty catheter that we have can fit through the working channel. If it is too firm, it would not be able to go through. There is no, we don't use an introducer in this. Going through, and then you use balloon it out. It was mentioned how you have to make sure you go beyond the Lilliquist membranes, both arms, the cephalic branch, balloon goes up, and at this point, that is being done by your assistant. And while you stay still, you widen it through. It is not as quick as what some of the experts have done, but this was with our experience here. Slowly try and make sure that you get to the waist of it. And all this time we're getting irrigation going. We try to widen that a bit more. Just advance that. And once that is done, we are able, therefore, to introduce the scope right through. There are bits of the membrane still there, Lilliquist membrane, but we are able to see the basilar artery right there. That's an example using the tube. It is not, we don't widen that anymore, but I think purists would say that's a sheath that we use for the Oi endoscope. The next one is using the forceps method. Same route into foramen of Monro. You can see the choroid plexus. There is Monro. And I'll just pause that. It is possible, as Mahmoud Qureshi had mentioned earlier, in terms of avoiding damage of the fornix, which is up there. We see the mammillary bodies, infundibulum of the third, and there's the forceps technique. And I think this is what was mentioned earlier using the LOTA. Clear. It is rigid, yes. So if it's quite firm, you'll be able to go through. Advanced. And then it can be widened. You need to have an adequate irrigation system going. Zoomed up, you can see well right through up the base. You can see the basilar artery and the pulsations going, and that's what one would like to see. I think it was mentioned earlier that you can go all the way down up to the fourth ventricle through the Puppontine system, I beg pardon. After doing that, that's how things should be able to work. Now, in terms of avoiding the complications, damage of the neural structures, you really need to know your anatomy, as was mentioned earlier, get the direction correct for the residents and for people who are not using things for securing it. Not much movement needs to be secured. For hemorrhage, if you do get little bleeds, you try and make sure that you give a lot of irrigation, and majority of the leakage tends to stop. The only problems are if you go through the flow of the third ventricle and you unfortunately have a catastrophic hemorrhage either from the basilar artery or spia cerebella, then that is a tragedy. Infection, we avoid that, the usual cleaning techniques. And as far as CSF leakage is concerned, when you have done the burr hole, what we try and avoid is you do an elliptical incision with only the pericranium, but when you are withdrawing the endoscope, you pack that using the Surgicel along the route. In terms of morbidity, if you are too close, sometimes it is possible to affect the pituitary axis. Neurological damage can also occur if you get the fornix and or the surrounding vessels. From the point of view of the techniques, we are lucky here that we've had the OI endoscope, which we have utilized. This has given us the opportunity to work it throughout the region. In the University of Nairobi, they have a flexible endoscope, which has been utilized also. But that is how we'd be able to take it. Now, that picture is of the glacier on Mount Kenya. Because of the work that we did with the Neurological Society of Kenya to be able to get the first rigid OI endoscope to enable us to start on this voyage. I've gone quickly. If you've got questions, comments at this point in time.
You mentioned as you're coming out with the I think at that point.
With the OI endoscope, or if you're using one without a sheath, when you extract the scope, the hole that is left in the cortex, you can insert Surgicel on that.
Personally, I agree with you, and thank you for the presentation. It's very informative and very interesting. And I want to stress the point of CSF leakage. We do a lot of maneuvers in order to avoid CSF leakage, especially in the mega hydrocephalus cases, because there is a lot of CSF that would be post-operative and it would be catastrophic when enhance infection and would not let the EPP work properly. So again, the scan incision has to be, if you are going to do a stent lab, it's better to do the periosteal lab in the opposite direction so that they cover each other. And for the corticotomy, I usually use gel foam because the gel foam is much more stronger rather than Surgicel. So I use the check from just like a finger, like one to seal the whole corticotomy. And again, if there's also CSF leak, I don't know your experience and Dr. Mahmoud Quraishi experience. Do you do lumbar puncture, lumbar drainage for 2 or 3 times, because it is already published about such cases? What do you think?
I have not been doing that. I must say that having done the numbers that we've done, CSF leak has not been a particular issue. What we have tended to avoid is, for example, in large hydrocephalic patients, to go directly through the fontanelle. We try to use our opening be just about a centimeter onto the bone.
Yeah.
You'll find in these large hydrocephalics that area, the fontanelle is really wide. The foramen of Monroe is quite wide, so we then use that as a flap, and then cover that as a flap. That's number one. Number two, I personally do not do a cruciate inclusion on the dura. I use a flap as much, even though it's through a small flap as well. So small, but to be sure that it's stitched with 4-0 Vicryl or 4-0 nylon. If you've had to have a burr hole that you've made, then I tend to seal it with bone wax as well. So with those maneuvers, we've not had a situation where CSF leaks. However, we have used a number of punctures when the fontanelle is not tensely bulging, but remains full, and it looks like the ETV is not
properly
working properly. It has been number of punctures on a daily basis, taking somewhere between 20 or 30 mLs at every opportunity. But doing a daily lumbar puncture on a child is pretty sort of horrifying for the little one. So we try as much as possible to avoid that, but we've done that on a few occasions. But that's not a practice that I feel comfortable with.
And in these 3 cases, did it work? Because you know, it has been said that if the ETV is going to work, it will work from day one, and if it's not going to work, it will not work.
Yes. So we've had, once you've taken out the CSF, you do see the fontanelle going down. We don't know what would have happened if we didn't do it, but we assume that that did help. It certainly did not do any harm. In terms of one of the techniques, and I was a little uncomfortable on the forceps side, because it was too close to the basilar. As a general rule, my recommendation when I'm showing this to someone who hasn't done it before is to measure the distance between the clivus and your mammillary body distance, and try to make the opening at the junction of 1/3 anterior and 2/3 posterior. I think that you're going to be safe because I know we do that, but I don't know why this was slightly different. This seemed to be almost 1/3 towards the basilar. And there are eclectic vessels, there are basilars that are a bit tortuous, and I feel very uncomfortable. I hardly ever use a forceps
alone.
But if the forceps is going to be used to widen the ostium or the opening, I tend to have the limbs of the forceps be perpendicular, so open transversely rather than towards the basilar. Because the basilar can sometimes, as it is pulsating, get punctured. That's just a small nuance on the technique, but the final thing that I do not promote, suggest that we do not do, is to use any cautery in the tuber scenario, because whatever reports have come on the injury to the basilar have been related to using cautery, because it retracts the basilar and the arachnoid around it, or the liliquis around it towards the cautery, and that's where the damage can happen. So those are small nuances that we use, and at most on a trajectory on the where to place the ostium, 2/3, 1/3, as I said, 1/3 above, 2/3 before, behind, and on a lateral side, try to avoid the 3 o'clock position. 11 o'clock or 2 o'clock is where at most one should put the perforation, because as we saw from the anatomy, the distance between the two posterior cerebrals is about 1.13 centimeters, 11 millimeters. And if you're going at around 3 o'clock, again, those come in harm's way, so one should try and avoid that. There are small nuances that one tends to suggest because of reading, because of talking to various colleagues. And in the Cairo course that we did, the WFNS course, we had several colleagues from around, and we actually have written up a guideline for ETV.
Where to put it?
And these are small points that we've mentioned. I'm just waiting for Nasser and Hamad to polish it up so that we can publish it in the newsletter and also send it out for publication as guidelines that are recommended now by the WFNS Neuroendoscopy Committee guidelines. So we hope that those will be published soon. But those are small nuances I thought I should mention.
Yeah, I have a comment regarding the use of the electrocautery. We can use, of course, I'm not suggesting this, but we can use the probe without using electrocauterization, without putting it on. So you can use it as just a blunt perforation.
I always do that.
Yeah.
So that's the technique that we use almost always.
Because sometimes,
It's very
as you've shown,
it is very firm.
The first video, the puberty is a little bit flexible, so you can't manage
to control it.
Session. So it's better just to use the electrocautery probe without putting it on function, just to make the hole, and after that you widen it. Absolutely. And I have another comment regarding the hemorrhage. I know this may be a little bit advanced level, but there are 2 already published techniques, and I have already managed to try some of them. Of course, not in purpose, but because I had the complication of not a catastrophic bleeding, because catastrophic bleeding is especially from the basilar or main big vessel. But whenever you have uncontrollable bleeding with irrigation, the first, of course, you have to irrigate a lot of irrigation. But currently we have the small chamber technique or closed chamber technique and the dry field technique. These are new 2 techniques to control hemorrhage. Of course, I'm not suggesting to use these techniques to control any type of bleeding. You do not have to to say that I will do the dry field technique to try the technique. No, it's not the proper way to think about it. But whenever you have some sort of bleeding that is not controlled with irrigation for, let's say, 20 or 30 minutes, you can just step for this dry field technique, which is you suck the whole CSF and the whole blood, then you, sometimes this is enough to control the bleeding and the coagulation process control the bleeding, or the other times which are very much more rare, thanks God, you can just start with the point of bleeding and cauterize it. The other technique is the closed chamber technique, and especially with the system where you have the sheath, the irrigation sheath separable, you can just introduce the sheath proximal to the site of bleeding and get the scope out so that you can just compress with the sheath the point of bleeding, and then you can just introduce your electrocautery to this point of bleeding. Again, these are a little bit advanced technique. It's not better to use it in the first or third or maybe the 10th case, but it's better to know these techniques because they are already published and you have to already use them.
I think before one goes on to that stage of doing that procedure, the teaching needs to be irrigate, and it will settle. Yeah. So I think only if you've noticed this, despite irrigation, the redness is increasing rather than reducing. That's the final one. Is some of these, and most commonly, the bleeder comes from the tubercularium, and in that situation, it's quite effective to reintroduce the full vertical loop and keep it filled up, inflated, and
some sort of
then the
pressure.
three common P's: patience, pressure, and prayer.
Yeah.
Finally,
Yeah.
we need to stop. So I think with that, unless you have anything else, that's excellent demonstration of technique.
Yeah, I think just as a belt and braces, sometimes if you've done all those layers, a little bit of tissue glue at the end can also help. But by that time, if it has gone through all the tissue glue, that will not hold very much. But yes, as a belt and braces. Yeah.
As the age limit changed for this, are you doing younger and younger patients, or do you still have a limit, age limit for this?
I think the age limit for ETV, as we have proven, 6 months is really the cutoff. And if you do it before, the chance of it working is very slim. So why do it? So I think it's still 6 months.
Now, there's a slight difference in our thinking. The thing is that if you look at Ben Wolf's publication, and he did them under 6 months, even with meningomyelin, we had a 33% success rate. So in our setting, because of the problems with shunts, when I go out to do the outreach endoscopy and ETV, I tell the parents, even if it's a month-old child, that because of the problems of shunting, and because there is a 1 in 3 chance that it will be possible that you will get away with it without a shunt, I am going to offer you the shunt. And working with our colleague in the peripheral hospital, say we will be doing our next mission in about 4 weeks' time. And if it hasn't worked, then we will have another look. And if the osteum is good, that means there is no adequate absorption. We will proceed to a shunt. So for that reason, I have and it's been published in World Neurosurgery as well. Experience with these. We tend to offer shunts earlier and earlier, and also that led us to the discussion on the African Federation of Neurosurgical Grading. Ben Okanga's dissertation and published a paper on that has shown that the variations are just as important in determining success of ETV. So if you've got a grade that has got a lot of multicystic hydrocephalus, has got a lot of scarring, and so even if the child is above 2 years, it'll be a problem. And you're more likely to succeed if you are in the lower grade where your CSF, where your floor, your third ventricle, your walls are all pristine. So those are determinants. So as a result of this combination of our trying to promote the African Federation Neurosurgical grading system and the fact that we've had this publications from Ben Wolf as well, where even with meningomyelocele, 33% were successful. We tend to use it as a first-line treatment earlier and earlier because shunting is good. I think it saved a lot of life. But in our setting, and again, the publication comes from a study at the National Hospital, where we had shunt infections and blockages in 33% of the cases. Now, 33% shunt infection is a huge problem. And in our setting, we seem to have very high rates of infection. Once you get a shunt infection, that child is doomed, and that family is in trouble for a long time. So we tend to advocate endoscopic third ventriculostomy as a primary procedure, regardless of age, and our results have borne that out, that we do get away in somewhere between 30 to 40% in the very young without a shunt. So why shunt? Yes, get away. But then the parent must know that they may end up having to have a shunt if it doesn't work in about 3 to 4 weeks.
And what's your experience about carotid exercise?
Yeah, I was trained with Shizuo Oi, and you should see the way he becomes.
When you tell that,
The moment you say CPC, his blood pressure, his facial expression, all changes. Yeah, and the reason is understandable. CSF is not a water bag for placement into the vesicles. It has a function. We are not fully, we do not understand CSF dynamics 100%. There is the pathway that goes through the extra ventricular system. It's a recognized pathway. And I believe, and I think Shizuo agrees with that that is actually the sewage system of the brain. And you need that CSF to wash away those toxins and the other things that are all the harmful metabolites or whatever they are, to wash them away. So it has a function. The only time I would advocate CPC is in a very significantly excessive hydrocephalus, where you're only doing it to assist the mother for nursing. So you do that and you do a CPC, it's belts and braces, but as a standard cure for obstructive hydrocephalus, I'm not in favor. I have used it, but
How many cases?
in my study, it's not more than 5.
Yeah, because I had this experience. I used it for 4 cases, and unfortunately, I had 50% mortality. I don't know. There's no explanation. We don't have postmortem. So, the best result of yeah, no,
there's not more than 5.
but I agree with you regarding the cases of hydroencephalus.
I think that's more from a nursing perspective.
Yeah.
And we have used that in one of our regional experts is in Tanzania, Shabani, and he does them beautifully. I demonstrate them very well, and picked the technique from him. I did not go to Ben Wolf. I picked the technique from him. I've used it in those 4 or 5 cases that I mentioned, but I am not opponent or in favor of CPC. I have to.
I think we probably have to see it.
Yeah.
Not quality.
Exactly.
You don't know what's happening. At some point, but no.
Yeah, you know, even there are some recent studies about the CSF dynamics and circulation against our solid knowledge, because they are saying that it is in a reverse way. It's not the imaging studies with the radioactive isotope and this, So still we don't know the proper CSF dynamics and the proper CSF physiology.
There's the Italian gentleman who I listened to, who is not a neurosurgeon, but a researcher on CSF dynamics. Really, listening to that lecture was convinced me that we were on the right line by not pursuing the CPC line very strongly. But for those who do it, good luck. But it's not something that I think.
Thank you.
Yeah.
Your presentation made a lot of discussion. Yeah.
Recording.
Okay.
All right.
Okay, good afternoon. Yeah, it's 12 now. And I'm Hassan Jalaluddin. I'm professor of neurosurgery and a neuroendoscopy consultant at Ain Shams University, Cairo, Egypt. I'd like to thank Dr. Mahmoud Qureshi for the invitation. I'd like to thank Mazen for the kind invitation from Karl Sturz. And I'm just trying to talk about complex issue. It's a complex hydrocephalus again, so I hope that I can present it in a simple way to just to know the important points in such an issue. Okay, this is from where I come. It's Cairo, Egypt, of course, and I hope every one of you can come to visit us soon. And this is the university where I work. This is the university campus. It is Al Za'afaran Palace, and this is the hospital. We have a lot of hospitals, but this is the largest one, and this is the private sector of the university, not the other sector. Now, we have a definition for complex hydrocephalus. The complex hydrocephalus could be uniloculated or multiloculated. Of course, the most common to think about complex hydrocephalus is the multiloculated hydrocephalus, where there are multiple cysts or locules isolated with multiple intraventricular separations. The less common definition for complex hydrocephalus is the uniloculated, where is a single cyst inside the ventricular system. It could be supratentorial, as in case of isolated lateral ventricle, or infratentorial, as in case of isolated fourth ventricle. Generally, the uniloculated is congenital in origin, while the multiloculated is post-infectious or post-inflammatory or post-hemorrhagic in case of neonates. I'm going to focus mainly on the multiloculated hydrocephalus rather than the uniloculated. And these are some images of the cases that we are going to show the videos later. And as you can see, the multiloculated hydrocephalus, you have a lot of locules. You can't find a connection between them. And this will lead to the problem. The problem is that there is no uniform surgical strategy to manage such cases, and the current options for multiloculated hydrocephalus to use the microsurgical fenestration of the separate compartments, either by craniotomy or by endoscopy, or shunt surgery, in which case we use multiple catheters placed in the separate compartments, or we can use a combination of these modalities. So we can use the endoscope or the microscope in order to connect more than one compartment to each other. Then we insert one or two shunts, and we have stereotactic procedure. But again, this a problem, because in case of placement of shunts, we have to use multiple shunts. We can use cystoperitoneal shunts. We can use multi-perforated catheters, where we use custom-made long catheters, or we use the ventricular catheters, and we add holes in different positions of the catheter, not only in the tip, in order to tackle multiple compartments within the multiloculated hydrocephalus. We have the stereotactic aspiration, just simple aspiration of the isolated cyst or the segregated CSF, or even the stereotactic shunt placement in different compartments, or stereotactic fenestration. The multiple shunts have the instance of infection, and the mechanical obstruction, and their removal has been problematic with associated risk of intraventricular hemorrhage. As for stereotactic approaches, they are generally safe, but thick-walled or mobile cysts may be difficult to fenestrate and are likely to recur, because in stereotactic, we don't make wide openings. We just do small openings. And as we will see, the opening, the diameter of the opening or the dimension of the opening is very crucial in order to maintain the communication between the cysts. Okay. This is a demonstration of multiple proximal catheters, and this is a demonstration of the removed shunts. And the goals of surgery are to control hydrocephalus and simplify the complex shunt by replacing all the multiple shunts with a single proximal catheter, single reservoir, and single peritoneal catheter, reduce the shunt revision rate, avoid implanting shunts if possible, and decreasing the operative mortality. Operative morbidity, I'm sorry. The available surgical technique in a comparison, we have craniotomy and we have endoscopy. And for craniotomy, of course, there is better visualization of the compartments and membranes, the easy fenestration and the excision of membranes, wide communication of the cystic compartment, and the hemostasis is more easily achieved compared to the microscope. The microscope has the advantage of being minimally invasive, avoidance of brain retraction as compared to open craniotomy, and less blood loss and faster operation time and shorter hospital stay. But the endoscope has the disadvantage of handling of significant intraoperative bleeding is not easy, as we have discussed previously in the previous minutes, but intraoperative bleeding can usually be easily managed by irrigation or coagulation, as we said. And on the contrary, the disadvantage of craniotomy is that there is profound CSF leak, and this will lead to increase the chance of subdural hygroma and or hematoma collection, and may lead to shunt malfunction later on. So the current practice is fenestration of the septum pellucidum, septum pellucidotomy, fenestration of the intraventricular separations, foraminoplasty, epiductoplasty, and EDV. So endoscopic fenestration tend to be performed more often for a treatment of multiloculated hydrocephalus, and the endoscopic management should be considered before placement of a second shunt. And some cases require the staged endoscopic procedure to adequately communicate multicompartmental hydrocephalus. The techniques of simplifying multiloculated or multicompartmental hydrocephalus, the burr hole placement is usually very crucial, very important. We have to select the burr hole position to make the cortical passage as short as possible, and to make to enter the largest cavity, and from which you can manage the other cavities. The trajectory will be take the endoscope to the membrane that separates the two cavities that need to be joined, and use the non-functioning pre-existing ventricular catheter tract to the ventricle, so you can remove just this non-functioning proximal catheter and introduce your endoscope through this trajectory. If there are multiple loculations, the trajectory should aim to communicate as many as possible, because we don't need to do multiple burr holes and we don't need to enter from many sites. And the membrane should be open with sharp technique with the diameter
at least 4 millimeter. And this is the superiority of the endoscopic maneuvers compared to the stereotactic maneuvers. And if the patient has never had a shunt placement, attempts should be made to break down all the membranes before communicating or committing to extracranial CSF diversion. Guidance, guided neuroendoscopy. We can use ultrasonic guidance or we can use neuronavigation guidance. This is an example of the ultrasonic guidance for to tackle these cysts and to communicate these cysts with each other. And this is the example of the neuronavigation guidance. So for ultrasonic guided neuroendoscopy, it gives live feedback. This is the most important regarding the ultrasonic guidance. It gives data about the ongoing intraoperative orientation. It's extremely useful both in localizing and assessing the direction of the endoscope during surgery, and it optimizes the depth of the cyst or determines the depth of the cyst, and the presence of solid structures beyond the cyst wall could be detected, and all of these are with a live feedback ongoing surgical procedure. As compared, as we will see, with the neuro navigation techniques, the other neuro navigation techniques. Any shift of the internal contents during or after fenestration could be detected again using ultrasonic guidance, and evaluation of successful fenestration. And this is a very important issue, evaluation of the successful fenestration and the communication between various compartments by viewing saline jet bubbles flowing from one cyst to another as seen on ultrasound. But still, ultrasonic guidance in neuroendoscopy is operator dependent. So when the operator is not experienced enough, ultrasonic may be a little bit cumbersome and may be misleading. And the requirement of a window in the cranial vault is another issue. So that in pediatric age group, let's say in neonate, you can use it through the transfontaneller opening, but in above the age of 2 years in pediatric age group, it would be difficult because it's a bare hole. It will not allow the probe of the ultrasonic guidance. We have small probes, but still we have to do a larger bare hole to detect the endoscope through our operation. And there is potential crowding of the operating suite because we add another device to the surgical field. For the neuronavigation guided neuroendoscopy, the framed techniques are not have no place in pediatric age group and neonates. So we use the frameless techniques. There is no need for cranial vault window, and this is compared to the ultrasonic guidance, and they are machine rather than operator dependent, again, compared to the ultrasonic guidance. But the two important drawbacks, it is not real time, no surgical progress feedback, and there's shift of intracranial structures. As long as we open the first cyst, all the other structures will be shifted. How to overcome this disadvantage of both techniques? We can combine both technologies at the same time, and so that we can have the ongoing live feedback of the procedure with the ultrasound guidance, and we can overcome by this way the brain shift. And to control the brain shift, we can use the continuous irrigation to maintain the anatomical landmarks. I'm going to illustrate some cases, but they are away from the presentation, so we have just to escape. Okay, all of these cases are the cases that I have presented the MLs before. The aim of this viewing of the videos of the surgery is not making an edited video, is to just show you that it's a lengthy procedure. It takes a long time, and you have to be patient during this maneuver, and you have to tackle the whole cyst as much as you can. So I'm going through the videos as rapid as I can. So the previous video. Here we are introducing the scope through the sheath, and this is once we get into the ventricular system, it's a little bit hazy, so we have to navigate with the scope in order to see the anatomy. As you can see, we have 2 fenestrations here. We proceed with the procedure. After navigating the ventricular system, we are aiming to see the transparent wall separating the cysts from each other. And these are the signs of previous infection and previous hemorrhage, as you can see here. I'm not sure if it is projected properly, but it is on the screen much more bright. After navigating through the whole ventricular system as much as you can, this is a rigid little lotoscope. Again, these are the signs of infection. We have chosen this part in order to communicate the 2 cystic compartments. And as we can see, we are just fenestrating the cyst. It's safe here to use electrocautery. We are away from tubercinarium. We continue with the electrocauterization, and then we perform the opening. We can just introduce the ventriculostomy forceps and open the forceps in order. Actually, this is a grasping forceps rather than a ventriculostomy forceps, in order to open the ostium and to widen it. Then we will introduce the Fogarty catheter, as you can see here, in order to widen the ostium or the opening. Then we inspect the cystic compartment we have opened, and we continue opening and widening the fenestration as much as we can. The minimum is 4 millimeters in diameter in order to communicate both compartments with each other. This is inside the isolated compartment. We are doing another fenestration from within the compartment we have just already opened. Again, we are communicating more than 1 compartment with each other, and we are using the Fogarty catheter to enlarge the fenestration. Another case. This is post-infectious, and as you can see, the CSF is altered, and the membranes here are much more clear, so that you can see the structures just behind. Again, we are navigating the ventricular system. We can see the choroid plexus here. Let's see. Yes. Then we start to communicate the compartments, the different compartments, with the same technique. We use electrocauterization, bipolar cautery, in order to make the fenestration and enlarge it with the Fogarty catheter, as we have seen. This is inside the cyst. The CSF has been stagnant for a long time, and the signs of infection are within. We are communicating the cyst from inside to another compartment. Okay, I have another case for uniriculated cyst, which actually has been an arachnoid cyst, quadrigeminal cistern cyst. And in this case, we have opened the, let's see the image at first. These are the images of the case. Just trying to enlarge. As you can see, this cyst is obstructing the foramen of Monro and causing hydrocephalus, significant hydrocephalus. And then we managed to open the cyst endoscopically. We will see the video. This is introducing the sheath and the scope, and then here is the foramen of Monro. We have the choroid plexus, the thalamus striate and anterior septal vein. And this is the cyst wall, as you can see here. And again, this is wall extending. We decided just to use this because it is much more transparent, so it would be much more easier to fenestrate it. Then we use electrocauterization again in order to make the ostium. And this is just from within the cyst itself. We are introducing the scope within the cyst. Here is from within the cyst. As you can see, the vasculature of the quadrigeminal cistern are apparent here and pulsations are transmitted. Then we continue enlarging the opening by sharp dissection. We cut as much more as we can from the cyst wall in order to avoid any recurrence of obstruction and any recurrence of closure of this cyst. There has been a point of bleeding here with the cutting, and we could control it just by bipolar electrocauterization. Here we go. As long as it is a minor bleeding, you don't need to irrigate and irrigate because the field is clear, so you can just use your electrocauterization to control the bleeding.
You're using bipolar.
Bipolar, yeah, bipolar. And this is, we are continuing dissecting the cyst wall as much as we can in order to remove as much part of possible as we can and to have a very wide and large fenestration. As you can see here, this is the end result. We have moved a large piece of the cyst wall, and there is this free communication between the cyst and ventricular system, as will be shown in the follow-up images. Here we go. This is the choroid plexus again. This is the thalamus striate and the foramen of Monro. Another fenestration in another point, and we continue just to communicate the cyst with the ventricular system. This is the follow-up imaging, and as you can see here, this is within 48 hours from the procedure. Okay. Another case of a quadrigeminal cistern. Cyst again. No, I would like to show another interesting case of post-infectious hydrocephalus and show the issue of having a double Liljequist membrane. It would be demonstrated here in a nice way. This is the image of the child. And as you can see, this is one of the mega hydrocephalus. And this is the video. this is getting back to the foramen of Monro. This is the foramen. As you can see, it's a long-standing hydrocephalus, and we have already septostomy already made. And as you can see, the choroid plexus, the thalamus striate, the aqueduct is already present. The foramen of Monro is very wide. And here we have the floor of the tuberous cinerarium, the two mammillary bodies. It is translucent. And we have just introduced our ventriculostomy forceps. And as you can see, after opening the first layer, we have another layer. So we have just introduced our Fogarty catheter in order to widen the first layer. Then we introduce the scope to see the second layer. This is the second layer of Liljequist membrane. And we are going to open it again with the Fogarty catheter. We are opening it. And still we have another membrane. So we have to widen this in order to reach the third membrane. This is some sort of a closed chamber technique again, as you can see. We are just using the sheath as a retractor in order to retract the stoma already opened, because we have a lot of flapping membranes. And again, we can see another membrane in the depth. So we proceed by widening this opening. And again, we proceed. This is the third membrane or the fourth membrane, maybe. Yeah. We are just opening it, but we are getting too close to the foramen magnum. And we have said that it's better to stop at this point. This is the end result with the spontaneous flow of CSF. Okay, this is regarding complex hydrocephalus. I have two other cases to share with you in order to, I know that this is a little bit advanced level, but it's nice to know that we can manage other cases with endoscopy. As regards, first of all, as regards our recommendation regarding the multiloculated hydrocephalus, the recommendations is that the keys to success of endoscopic treatments are early diagnosis and early treatment, and these are achieved in part because of the improved morphological and functional definition obtained using the recent MRI sequences, according to the company that produced the machine. And all efforts should be made to allow the widespread use of neuroendoscopy at an early stage of this disease, and this is what we are doing or trying to do in this course. And this is a case of oculosis. You can consider it as a complex hydrocephalus because this oculosis is causing a significant hydrocephalus. So, if you are going to manage such a case with shunt, you need to put multiple shunts. So you need to need at least 2 catheters in each side, because the communication between each side is obstructed by this colloid cyst. And this is the video of this case we just entered, and this is the colloid material aspirated. This is the aspiration of the colloid material. This, of course, is an edited video for the sake of the time. This is the cyst wall, and this is the colloid material. We are aspirating the colloid material as much as we can, and again, we are taking by grasping forceps colloid material, and this is within the cyst itself. This is the cyst wall. We are electrocauterizing the cyst wall in order to avoid recurrence. And this is the aspirated contents, and this is the some parts of the cyst wall. These are the preoperative images, and these are the immediate postoperative image with near total removal of the cyst wall and no recurrence till now. Another case is of suprasellar third ventricular craniopharyngioma in a male patient, 18 years old, presenting with visual disturbance with immediate postoperative resolution of the visual symptoms. And as you can see, there is a solid part here in the sella, and there is a large suprasellar component just reaching the third ventricle and filling the ventricle. this case, I have also managed it endoscopic transventricularly, and this is the introduction of the scope through the right lateral ventricle. This is the fornix, and this is the foramen of Monroe, and this is the cyst, the craniopharyngioma cyst, and this is the choroid plexus, and then we are just electrocauterizing the cyst in order to open the cyst, and after opening the cyst, this is the classic craniopharyngioma fluid coming out. We are aspirating the cyst content. This is continuing aspiration, and as you can see, the cyst collapsed at all. So this is the cyst after collapse, and we are just introducing the scope within the cyst, and this is the residual craniopharyngioma fluid. This is from within the cyst. These are the preoperative images, and these are the immediate postoperative images. This is the amount that we have aspirated, around 30 cc, and this is the part of the cyst that we have removed. And thank you. Okay. Any question? Any comments?
What system are you going to aspirate?
I'm using the Lotta. I have the big Lotta and the little Lotta. Yeah.
Interesting. Any patients reform the system?
I have a few questions from someone that's watching on the internet.
Yeah, okay.
Yes, hi, this is Dr. John Bennett moderating from Miami. I have a few questions from Rakesh Av from New Delhi, India. One of the questions is chances of basilar injury. That's his first question. Second question is how to tackle bleeding into the ventricles. Let's start with those two, please.
Okay, so regarding the basilar injury, we have already made a discussion around 30 minutes ago, but again, to avoid vascular injury to the basilar artery, you have to use blunt techniques. You don't need to use sharp techniques, and you have to avoid using electrocauterization in function. I mean, you can use the probe as a blunt instrument to make your fenestration at first of the tuber cinerarium, and after that you widen this fenestration with the Fogarty catheter, but it is not recommended to use the electrocautery in function in order to cauterize the tuber cinerarium, because this would lead to or may increase the chance of this basilar artery injury. Another issue is to avoid using the ventriculostomy forceps in a way that the blades of the forceps open in a way such that it touch the basilar artery, so that it has to be perpendicular to the artery rather than parallel to the artery, so that this is another way to avoid the basilar injury. And the most important, of course, preoperative is to study the images of the patient as much as you can in order to know the prepontine cistern diameter and the dimensions in front of the basilar artery, because sometimes you can see that the prepontine cistern is too small or too narrow in order not. It would be difficult to accommodate your instruments, and it will lead to increase the chance of basilar artery injury. So in these cases, you may think twice before just doing your ETV. So the preoperative studying of the images is very crucial and very important. Regarding the second question, as regarding the control of bleeding, and we have already discussed it in a panel discussion 30 minutes ago, the most important, again, is to know the anatomical landmarks and to follow up these anatomical landmarks as much as you can. If you strictly follow up the anatomical landmarks and you move your scope confidently and with slow movements, this is the guideline to avoid injury to any vessel. But still, with using these techniques, the chance of injuring the vessel and then having hemorrhage could happen. And in this case, irrigation is the most important technique to control this bleeding. So you have to irrigate, and wait as much as you can. And you may irrigate for 30 minutes or maybe 45 minutes and to have a clear field just before shifting to some new modalities which are not recommended to be used from the start, which are the dry field technique or the closed chamber technique. But they, as I said, these two modalities of controlling bleeding are not recommended to be used as routine methods. Any other question, John?
Yes, so Rakesh has one more question. What are the most common complications on the post-operative period, and how do we deal with those?
Okay, let's say that the most important, of course, is the failure of the technique or failure of ETV, because the problem is still there and you have to manage the problem. And whether you decide to do a redo ETV or to just go for a placement of a VB shunt would be a problem again, because you have already told the family and you have already counseled the family regarding the options, and you have already told them that the ETV is a better option rather than VB shunt. Of course, you have to tell them pre-operative that the chance of failure is there and we may use a VB shunt again. Another issue regarding the post-operative complication is the CSF leak from the site of puncture of the burr hole, and there are a lot of maneuvers and techniques in order to avoid this leakage. As we have said, that it's better to use multi-layer closure techniques. So if you can use a bone flap, if you can use a pericranial flap in a direction different than, or the opposite direction to the scan flap, if you can use a dural flap, as Dr. Mahmoud Qureshi said, and try to close it even if you have a small burr hole, try to use or to have a dural flap rather than the cruciate incision, and after that try to close the dura as much as you can. Then you can pack the corticotomy site with gel foam or Surgicel whatsoever in order to avoid CSF leak. And if you have a burr hole wide enough, you can just plug this burr hole with bone wax. All of these techniques could help to manage the CSF leak. There are other less complications or minor complications such as infection, and sometimes in complex hydrocephalus, you will need to do multiple endoscopic surgeries in order to manage such a lesion. Dr. Mahmoud, do you think that there are other complications? Because our colleague from New Delhi is asking about the most important complications to tackle. Do you think other than CSF leakage, other than failure of ETV, is there other complications?
One of them, but an additional one, you've mentioned the most common ones, is obviously a large subdural hygroma.
Yes.
And that can be a bit tricky because people have tried putting burr holes and drain them like a chronic subdural, but they just continue.
Yeah.
I haven't used it many times, but had occasion to use a subdural, subgaleal sort of shunt.
Communication, yeah.
That has reduced it. I don't know how commonly you have used it, but that's something that is an additional complication because the hygroma persists. It seemed to be causing some kind of mass effect and prevents the brain cerebral cortex from expanding.
Yes.
So doing a subdural subgaleal shunt is sometimes that we use. Do you use that?
Yeah, I don't have an experience regarding this because all the hygromas I have with the shunts, not with the, yeah. And yes.
And yes, what you said, we've done subdural peritoneal shunts, but monitored it in the subdural space. It tends to obliterate within 3 months. So we're trying to make sure that if it's cleared within 3 months, you actually take it out. But if you do not, it gets all secured and then you can't take it out at all. So I've done lots of use of video, lots of use of.
Yeah, thank you. It's okay.
Thank you for the presentation. It was quite nice. Regarding the multilocated shunts, else that helps you govern the decision of ETV? And you touched on it that you might do repeat ETVs. But in the case that you showed that had the stagnant with what looks like the colonies, when you saw that, did you really coming back? Do you do a washout? Do you do a protein?
Yeah, in that particular case, maybe I have not showed in the video, but I managed to do ETV at the end of the procedure, and I do remember that it succeeded. Yeah, it happened to succeed in this particular patient. You know, thanks God, we don't have a lot of multi-regulated complicated cases because they are cumbersome cases, but the results are so far are good.
It is one. This is one of the situations where sometimes you cannot get to the tuberosinium, you cannot see the
Yes.
floor.
Yeah.
And rather than give up at that point, after having opened up the various systems, you cannot get to the tuberosinium and go fluid into the basal system. Is one indication where you might want to use lamina terminalis.
Yes. I agree with you.
If you can widen that, get to the lamina terminalis, and open it, you've basically gone into the basal system without having gone through the floor. So this is one indication where one can use a lamina terminalis.
Yeah. I have used it once and it worked, but yeah, I think it's a nice technique.
The only problem is that
this is what,
in the smaller ventricles.
Yeah, it is, and it needs a little bit posterior per hole, and you are not planning this from the start. So yeah.
But if that is the main issue, it's still worth making a posterior hole and approaching.
You mean the same procedure?
Is in the same procedure.
Yeah. So you take the scope off and you
putting it back, making another.
This is another important issue to discuss and to know your experience regarding biopsies from posterior third ventricular or pineal region lesions causing hydrocephalus, and if you are going just to make ETV and a biopsy at the same level. So do you use two per holes or a compromise per hole in order to tackle ETV and have the biopsy? What's your experience?
I think doing two per holes is more appropriate.
Yeah.
Because by doing a compromise, you're compromising the ETV, putting the phonics at risk, and not getting adequate
enough.
So I think putting the burr hole for the ETV in the proper position, unless you can really widen it, that's a different matter.
Yes.
You can actually do a small craniotomy.
Yes.
In which case it would be fine, because then you can move the scope. But I would prefer putting the burr hole for the ETV in its recommended position, and then looking at the trajectory on the MRI scan and putting the burr hole. Hopefully it will not be right on the forehead. Yeah. But if you can get it just behind the hairline.
The hairline, yes, it is.
That's more recommended rather than compromise burr hole.
Yeah. Any other comments? Any other questions?
The next references, were you able to connect it with the first explanation?
In that case, no, because it's already within the ventricular system, so you can just connect it with the ventricular system. You don't need that. But I have made already an ETV in this case. But I have another interesting case. If time, is it okay, Justin? It's a complicated
Because
case.
This is the time for case discussion. Anyway.
Yes, okay. So it's a complicated case, and just to know your experience about it also. So let's try just to find the case because it's not ready with me.
Cysts like that, they came back much later.
Yeah.
2 years or so.
Should we close or you want to close? No, it's okay.
Was the osteum large enough?
We got resected the whole wall, but it still came back where we weren't able to go down.
Okay.
This was
I just want to close this. Do we? Oh, it's fine.
No.
No, I have closed the. It's okay. Okay. Thank you.
5 centimeters, very slowly. Yeah.
So it's okay. It's okay. It's okay for me.
Yeah. 2 years later, patient comes back with a large cyst.
Something is closed.
Exactly. So that's what now the discussion.
The question is whether one should have.
No, it was almost pretty much like that, but it's this. Okay, his was a lateral third ventricular assist with deployment system. This was a lateral ventricular system going into the bed. So we just, once you enter the lateral part, you would quite.
But you didn't perforate.
No, not even to go